Good day, ladies and gentlemen. My name is Patrik Tosenovsky. I'm vascular surgeon with venous interest. I would like to introduce you today to management of pelvic congestion syndrome. This presentation will take approximately 20 minutes and it is associated with interview of the patients, which will take approximately 9 minutes. I hope you will enjoy it. Thank you. Pelvic congestion syndrome. This is an educational program. The intention is to raise awareness of pelvic congestion syndrome amongst medical students, general practitioners, and specialists who may see such patients. If you're not a healthcare provider and if you have similar symptoms and signs, you should discuss your condition with your GP. This is not a guideline for patients. Pelvic congestion syndrome is a condition associated with symptoms like ache or pain in the lower abdomen and pelvis, dyspareunia, vulvar varicosities, irritable bladder, sometimes hemorrhoids, and sometimes chronic vaginal discharge. In the differential diagnosis, we have to think of endometriosis, pelvic inflammatory disease, pelvic adhesions, and ovarian pathologies. To understand the pathophysiology of pelvic congestion syndrome, it is very important to understand the anatomy of the venous drainage. Essentially, there are 4 veins draining the pelvic organs. One is right ovarian vein, which joins usually IVC below the right renal vein. A second one is left ovarian vein, which is draining the left part of the pelvis, and the ovarian vein is joining left renal vein. And then on both sides there is internal iliac vein, which is draining significant amount of blood from the pelvis, and those 2 veins join left common iliac vein here in the pelvis, and then the blood from pelvis should go always through the IVC in one direction. Same with the ovarian vein. We will show you the typical signs and symptoms for PCS based on the literature review and based on the review of more than 100 respondents of Facebook support group for pelvic congestion syndrome. We did not know the demographic data for those patients. We also did not know their comorbidities. The most common complaint was pain related to the intercourse in 88% of females, either during or after. 88% patients also complain of chronic pelvic pain or ache or lower abdominal pain. 69% of respondents complain of feeling of having full bladder, not all the time, but very often, or even all the time. 63% complain of hemorrhoids. 57% had unusual menstrual bleeding. 48% had swelling of the vulva. 48% had chronic vaginal discharge. Vaginal dryness was also recorded in 38% of women. And finally, 34% of respondents complained of having varicose veins in their private parts or in the proximal thigh or perineum. We would like you to introduce you now to some of our patients who were diagnosed with pelvic congestion syndrome. These women will share their stories with you. They were asked about their symptoms and signs and how they were diagnosed with PCS.
I feel like my life's over. We had got to a point with my husband where I said, I don't think I'm going to reach my 40th birthday, and we'd made arrangements for what would happen when I pass away to look after my children. Sorry. Because I couldn't be a mum, and I couldn't stand to cook, so I had to have a stool to cook because the pain was just so unbearable.
Really, my symptoms have been going on for many, many years, probably since my teens. Aching, burning in the leg, pelvic congestion, very heavy period, hemorrhaging, a day off school, once a cycle.
They probably went right back to when I started my period, I think at 12, and that's when I really noticed the problems. I was always very, very tired. My periods were horrifically heavy and excruciatingly painful. I had to have time off school, very foggy headed.
It's constant pain all the time, but the day before, the day of, and the second day of my period are the worst. If I sit down, I I'd feel almost sick, and from the pain, I'm actually sick from the pain. So my legs feel like they are weighted down to the ground. The one day that really got me to see the doctor, I was walking down a hallway and I just fell to the ground in so much pain.
So I was really tired. My expression was that I couldn't breathe, and I felt that my heart forgot to beat.
Pain down my side was excruciating, so it would be down this side. I would struggle to wear a bra, my lower back.
Really in this sort of lower left side, so it was sort of like very localised on the left here, but very much also heaviness and pain up here. I felt sort of times as though I was sort of having a kidney problem, but it really just came and went, like flank pain. And it was just sort of this daily sort of like coming and going sort of heaviness or sharp pain that would just be there.
It just feels like you're stuffed, your whole lower abdomen stuffed with cotton wool or something, rammed in there, huge pressure. I couldn't get in any comfortable position.
Obviously when I met my husband, sex was extremely painful, and it wouldn't just be painful at that moment, it'd be painful for days. And it was really embarrassing and quite sort of mentally that's quite debilitating, and to have that in that relationship. And then when I was pregnant, I was extremely unwell. I think it was about 6 or 7 weeks after having my first baby, I was given I think it was 17 cortisone injections into the cesarean scar to relieve the pain. I left the surgery, went straight out and collapsed.
During my pregnancy, main symptom there was this really stabbing hot poke of pain, which did not go away. Sort of just ignored, dismissed a bit because, you know, you get aches and pains when you're pregnant, but it was agonising. I had developed varicose veins. They were rope-like. My left leg much worse than my right.
I had varicose veins since pre-teens. I can remember, and it just got worse and worse.
The varicose veins were horrific to the point where they were on the soles of my feet, so I'd have to crawl around the house. The obstetrician said, well, women have been having babies for thousands of years, get over it. After my second pregnancy, I became extremely sick. I had pneumonia for about 9 weeks, which turned into chronic bronchitis for 18 months. And then the respiratory doctor had this great idea that actually, why is your iron so low? Why are your periods so heavy? And he referred me to a gynecologist, and then that's when they realised that I had probably pelvic congestion syndrome and May-Thurner.
I think I was relatively lucky. I think I was quite quick. It was probably the pain. I went and saw the doctor about April, May of 2018, and then it took me to a gynecologist first, and then the gynecologist heard about you, and then I'd had the surgery by the end of that year. I don't think the GP knew exactly what was going on. I think that her first point of call was the gynecologist. I'd had a history of endometriosis, so she just said, go there. So that's where I went.
I got an ultrasound done and it showed nothing.
The doctor feels sometimes the best advice is, you know, just you need to grin and bear it. There is a perception out there that the vascular system is not that important. In other words, there are not lethal consequences if you don't have a healthy vascular system. I would strongly disagree with that.
I would say in 2012 I broke my ankle, and that's really where the leg was never the same since then. And I had gone for multiple scans, constantly complaining, Dopplers, and I could forget all the different ones. I've been for multiple ones, different scanning companies, and they were all 5 minutes, 20 minutes, half an hour if I'm lucky. This guy took an hour. He was thorough, he took his time, and he specialized in venous scans. On that scan, he picked up something was wrong. He picked up I had May-Thurner. He picked up a compression, but they didn't realize how severe it was. The intervention was a stent in my left iliac vein.
I had a stent put in my left iliac vein and a coil to embolize my left ovarian vein.
I had a stent in my left iliac vein and inferior vena cava.
But the thing that's made the biggest difference for me is the stent. Definitely. I'd say it's like I've got a hole in my pelvis because it's so free. All the congestion is gone.
The pain, it reduced significantly. And it wasn't in a case of months, it was literally the next day. I actually felt like, yeah, I can work again. I've got my life back. I can be a mum, I can be a teacher, because I had resigned from my teaching career and given up any chance of permanency, which is a massive thing for teachers.
Earlier in the week I was in the hospital, and it was quite painful for the first few days. There was quite a lot of pain. I woke up with a lot of pain. But then that eased off, and by the Sunday I was actually on Rottnest at a concert.
That has been the most life-changing event. Previously my energy levels were, say, a 1 out of 10, and I'm not exaggerating. It would take me hours to get ready and dressed. I am now at least at a 7. I don't run a marathon. I'm not a person that does a lot of exercise, but my mind is clearer. I feel I can breathe. I don't feel heavy and lethargic.
The pain has subsided dramatically. Having the iliac vein stent done is the best thing I ever did. It gave me my life back.
I think we went on holiday perhaps about 6 weeks after, and I was jumping off the Bustleton jetty with my children, and I just said, I can't believe that I can do this. It just felt like I'm normal now. But I did have, after that, a sense of grief for a while, because I felt like, hold on a minute, I've been complaining to a doctor since I was 16. At the time I was almost 40, and I thought, this is the best part of my life, and I've always been in pain, and everybody's dismissed me.
I think that if there had been some sort of test, I think if it was possible for me to have that and it was diagnosed and I had the stent, I probably would have, I'm nearly 60, I think I would have had 40 years where I would have been up and around and walking as long as everyone else and feeling better. But hey, I've got there now.
The epidemiology of pelvic congestion syndrome is not well known. Some suggest that up to 30% of women may have some form of PCS. About 20% of patients in the gynecological practice complain of chronic pelvic pain. We know some predisposing factors. Family history is one of them, age between 30 and 50, although we tend to see younger patients as young as 16 or 17, and also we see 60 or 70 years old. Not very typical though. More than 2 pregnancies were associated with ovarian vein reflux, and in some papers up to 20% of females were never pregnant. Pelvic surgery, estrogen therapy and obesity are other predisposing factors. However, we tend to see also very skinny women. The etiology of PCS is not well understood. However, most people believe that venous hypertension seems to be responsible. It is caused by either reflux or obstruction, or a combination of both. We tend to see reflux mainly in the ovarian veins and also internal iliac veins. Obstruction typically is in the left common iliac vein or left renal vein, or combination of both. Diagnosis is made based on clinical assessment and history plus medical imaging. We start with ultrasound scan. Usually we start with transabdominal venous scan, focusing on iliac system, IVC, both ovarian veins and both renal veins. If we need more precise assessment, we start with either CT angiography or formal angiography with special features, like on this slide you can see dynamic CT angiography, where the contrast is being injected through the femoral veins, and as it passes the iliac system and IVC, it's captured, and because the fluoroscopy machine is rotating around the patient, you can get a 3-dimensional picture. On this particular case, you can see significant compression of the left common iliac vein, which is the most common obstruction site of all in the pelvis. It is caused by right common iliac artery, and you can see that the blood is being captured also in the collateral vein, which is in this case ascending lumbar vein, and also in branches of internal iliac vein. In fact, the blood is being forced through all those collaterals because the compression is significant. On this slide, I would like to show you compression of the left common iliac vein on formal venography. If you look at the left-hand side of the slide, when I turn the venography on, you will see that blood from left iliac vein goes across the pelvis to the right side and up to the IVC. If you look at the right hand side of the picture where the venography is still, you would appreciate that the outline of the IVC and junction of both iliac veins look probably like this. There would be the compression of the common iliac vein, and the blood is not going through the blockage. It goes rather across the pelvis to the right iliac vein and through the right iliac vein to the IVC. This is called May-Turner syndrome, and it increases pressure in the pelvis. In some cases, it increases pressure also in the entire lower limb, and it can easily cause DVT in some susceptible patients. But in terms of pelvic congestion syndrome diagnosis, this can be quite significant. Apart from the most common location for compression in the venous system, which is left common iliac vein, I will show you not very commonly seen compression, which is left renal vein. As you will see on this venography, left renal vein can be significantly compressed, and the blood will be forced through the ovarian vein on that particular side, and the left renal vein will be very large because it will be playing a role as a collateral, draining the whole kidney. And the left ovarian vein will be feeding large varicosities in the pelvis. We will see that the contrast is being injected into the left renal vein, and then the blood is falling through the huge left ovarian vein. And as you can appreciate on this picture, the left ovarian vein is filling up a lot of veins in the pelvis, which increases pressure on all those pelvic organs. Now, if we go to the drawing and still picture of the venography, you will see that the blood from the left kidney, which is somewhere here, is not going that way, as the arrow is suggesting, but is going through this ovarian vein. That means that the blood from the left kidney will be preferably drained through the pelvis and through the right iliac system back to the IVC. Different patient with very similar picture you can see on this venography. You see that the catheter is in the left renal vein, the kidney will be here, and the blood is, instead of going this way, it is preferably going through the large duplex ovarian vein down to the pelvis. The cause is same in this case as it was in the previous one. It's a compression of the left renal vein by SMA. If you have a CT venography, it can give you this picture where the left common iliac vein is being squashed, as you can see where the arrow is pointing. This is significant compression of the left common iliac vein. However, we must not forget that a lot of people have completely asymptomatic compression of this vein, and these people are not to be treated by any intervention. But those who have symptoms can be and should be treated. MR venography is another very good tool, as you can see on this picture. The typical location of the compression right here. Filling defect in the left common iliac vein caused by artery. You can see enormous left ovarian vein here, filling up quite large varicosities in the pelvis. This particular woman had a combination of left renal vein compression here, left common iliac vein compression here, plus right ovarian vein, which was as large as the left one but not visualized in this picture, plus the left ovarian vein reflux. Combination of CT scan, MR venography with formal venography in a cath lab plus intravascular ultrasound gives the best chance to correctly diagnose people with PCS. Intravascular ultrasound, or IVUS, is the additional tool that we can and should use as often as we can. However, it is not Medicare funded in Australia. There is access to it, and According to the most recent publications, it is the gold standard of venous imaging. On this picture you can see imaging of left renal vein which is being compressed. In order to diagnose PCS correctly, we have to rely on clinical symptoms and signs patients give us. Doctor has to, however, be highly suspicious. Gynecologists and GPs are encouraged to refer patients to vascular specialists with venous interest if they're not happy with patient's progress. Imaging is a good start, however, good imaging is based on not only good equipment but also experience of the sonographer. Transabdominal ultrasound is a good start. Transvaginal ultrasound is relatively easy to perform and cheap and quite reliable and can give us some information about whether there are any varicosities or not. Formal venography with intravascular ultrasound, with or without CT and MRI, is absolutely necessary, and in my opinion it is very important not to diagnose patient only with reflux in the ovarian vein. It might not be a complete picture. Treatment of pelvic congestion syndrome is both medical and surgical. The medical one includes painkillers, flavonoids, and progesterone. Surgical involves hysterectomy or oophorectomy. During the last 20 years, percutaneous endovascular treatment was very successful, and it was mainly focused on ovarian vein reflux. Based on the systematic reviews and meta-analysis, the overall success rate for ovarian vein coil embolization is about 75%. We believe that if the combination of obstruction and reflux is the cause of PCS, then coil embolization alone will never be 100% successful because of the underlying obstruction being untreated. Percutaneous endovascular treatment in 21st century should include treatment of both obstruction and reflux. Before the intervention is performed, however, the understanding of the circulation in the venous system of that particular patient is necessary, and therefore dynamic imaging including ultrasound and also formal venography and IVUS should be involved. The treatment of obstruction is venoplasty and stenting, and treatment of reflux is coil embolization or embolization with any other technology available these days. This is the last slide of the presentation, and you can see on the left hand side where the left common iliac vein was being compressed, and you can see significant collaterals in the pelvic circulation here and also here and here, and the filling defect in the left common iliac vein. In essence, this whole area is significantly compressed, therefore the blood goes through the pelvis and is increasing pressure in the pelvis. And this is the same patient after intervention. You can see the stent being placed in the left common iliac vein, and you can see that collaterals have disappeared and the flow was, without any significant obstruction, very smooth through the stent. In the end, I would like to thank all participating women for their courage to face the camera and share their difficult stories. We hope that this will make the PCS more understandable and much less troublesome diagnosis in the future.